Thank you. Thank you so much. Good evening, everyone. Thank you, Srini, for that kind introduction. I really want to first thank all of you for your time and taking out time of your busy schedule on a Tuesday evening to join this webinar. I really cannot thank you enough. And I also want to thank you all for your support. Without your support, my practice and my program would not be what it is today. So I'll go ahead and share my screen and we'll get started. So I'll go over a little bit of basics as well, because we have some APRNs also in the attendees. So I'll discuss some of the basics of BPH and how we select the patient for treatment and so forth.
And Dr. Bhatia, I just wanted to give one kind of note for today's webinar. If you have questions at the end, we will have a Q&A session. So please stay tuned and we'll get to you.
Yeah, so everyone can post their questions in the chat box or in the Q&A box. That will be great. Thank you. So these are my disclosures. Most of my disclosure are actually more like past speaker relationships with some of the industry. So just very basic, in terms of a prostate gland, what function does the prostate gland has? Well, it contributes 1.5 to 2 ml to the seminal plasma and is responsible for production of some secretory proteins like PSA and PAP. But when we look at the autopsy prevalence of histologic BPH, we all know that over 50% of men at age of 50 and 90% of men at age of 90 will have histological BPH. But how do these people present? All the people who have histologic presence of BPH does not mean that they're going to have symptoms, lower urinary tract symptoms. So essentially a couple of sources of symptoms, static component and the dynamic component, and then the bladder response. So static component essentially increase in number of epithelial and smooth muscle cells and increase in the connective tissue. The dynamic component of obstruction increase in smooth muscle tone and resistance from the enlarging gland. And then the bladder response, which is variable, may vary over a period of time. The spectrum goes from an overactive bladder to detrusor underactivity. And again, this all information is really for the mid-levels who are in attendance today. And most of the medications which are used to treat lower urinary tract symptoms due to BPH act on either static component or the dynamic component or the bladder. So like a finasteride would add on static component, alpha blockers would act on the dynamic component, and then you have antimuscarinic, which will act on bladder. So these can produce number of voiding symptoms, lower urinary tract symptoms. And what are those symptoms? How do these patients present? So they will present either with storage symptoms, including daytime frequency, urgency, incontinence, or nighttime frequency, which is nocturia, or some voiding symptoms like slow stream, splitting, intermittent stream, hesitancy, or straining, or post-micturition symptoms, including incomplete emptying and dribbling. So if we take a cohort of men over age of 40 years, the histologic BPH would be prevalent probably around 2/3. Lower urinary tract symptoms will be probably half of those patients. And in some of those patients will have prostatic enlargement and infravesical obstruction, which means the enlargement enough to cause obstruction due to dynamic and static component. And these are the group of men who are really the target for the therapy for enlarged prostate. So we strictly follow everything according to AUA guidelines, American Urological Association guidelines. We do it, according to the book. So recommended evaluation, relevant medical history, assessment of lower urinary tract symptoms, discussion of symptom severity and bother. We'll spend a lot of time on this with our patients. Physical examination, again, we work with in very close collaboration with our urology colleagues. So the DRE, most of these patients already have all these things done, but we do discuss the symptom severity and bother in detail. When it comes to pre-op testing, again, most of these patients have the workup done from our urology colleagues. Assessment of post-void residual, assessment of prostate size and shape, and then additional considerations like uroflowmetry and pressure flow studies. So uroflow pressure flow studies are not mandatory and are not done in every patient, but whenever it's mandated or whenever it's indicated, we will do it. So what is an IPSS score? So IPSS score is essentially an international prostate symptom score, which is 7 components: incomplete emptying, frequency, intermittency, urgency, weak stream straining, nocturia, all the symptoms which we saw as a part of lower urinary tract symptoms. So when these are graded from 0 to 5, 0 to 7 is mild, which is essentially normal, 8 to 19 is moderate, and 20 to 35 is severe. As per AUA guidelines, the indication is moderate lower urinary tract symptoms and above, but most of us in our clinical practice treat patients with symptoms of IPSS score of 13 and above. But again, there are many other factors to be considered, not only the symptom score. Now, quality of life is a part of this symptom score. 0 delighted, 6 terrible. Anyone who has 3 and above, quality of life is really kind of like as an indication for treatment. What is uroflow? Uroflow is essentially measuring the flow rate of urine. Less than 10 ml per second is predictive of bladder outlet obstruction. Post-void residual, how much a patient is retaining in the bladder every time patient is urinating. PVR greater than 50 ml is considered significant. More than 300 ml is considered chronic retention and should be addressed. Baseline MRI. So we do baseline MRI. You know, our background is interventional radiology. We like to see, but now I think latest AUA guidelines does include baseline prostate size and shape, which was not the case before 2018. But we'd like to do MRI for a lot of different reasons. I like to see the symmetry. I like to see the transitional zone, peripheral zone ratio, which I think is very important in determining the success after the procedure. I like to see the volume, the median lobe. I don't treat patients really more than 3 centimeters of median lobe. I don't treat patients if the transitional to peripheral zone ratio is 1:1, which means it's a pretty prominent peripheral zone. And obviously, we want to rule out any prostate cancer. So in terms of workup, the additional levels, what we look at is PSA, but again, this is all done in close collaboration with actually all of you, with our urology colleagues. And we look at the history of prostate biopsy, prostate size. Some patients cannot get MRI, so they will get a transrectal ultrasound or a transabdominal ultrasound. Urodynamics and uroflow as indicated, and then post-void residual measurement. So these are the things which we evaluate to determine the candidacy of the procedure. But when we follow this AUA guidelines in terms of intervention for BPH. What are the absolute indications? Patients who present with urinary retention and they have failed voiding trials. Patients with recurrent UTIs. Patients having renal insufficiency secondary to BPH in gross hematuria. These are like 4 absolute indications. When it comes to relative indication, moderate PVR volume, but again, more than 300 is definitely considered significant and should be addressed. Moderate or severe symptoms, failed medical therapy, these are all relative indications. So where does PAE fit in? Where does prostate artery embolization fit in? Well, men who wish to avoid any sexual side effects, because PAE does not have any adverse effect on erectile function or ejaculatory function. Patients who are poor surgical candidates, and I think this is a bulk of my practice, number 2, number 3, and number 4. Poor surgical candidates, failed. When I say failed surgical procedures, what I mean is that they have had a surgical procedure in past, 3 years ago, 5 years ago, 7 years ago, and now they again have recurrence with the regrowth of prostate and they don't want to undergo another surgery. Large glands, more than 80 grams. So just again for APRNs to put in perspective, less than 50 gram is considered small, 50 to 80 is moderate, more than 80 is considered enlarged. Patients with hematuria and patients with acute urinary retention, some of the common presentations post-surgical, they will go for like a hernia repair, they'll go for like knee replacement, and then they cannot get out of retention. They just underwent a major surgery and now they don't want to undergo another major, relatively an invasive procedure or surgery. So these are like very specific indications where embolization can really be very, very helpful. Who are the poor candidates for embolization? Well, one size does not fit all. So small prostate size, less than 50 grams. If patients, there are a lot of patients who come to me and I actually refer them back to urology because, smaller prostates will not respond very well to embolization. Very large median lobes, more than 3 centimeters. Patients with predominantly irritative symptoms, patients who have active UTI, and patients with renal insufficiency, especially if it's significant renal insufficiency, especially creatinine 2 and above. My cutoff is, creat of 2. Rest I can optimize and I can still treat them, use carbon dioxide, instead of iodinated contrast, but still we are able to treat them. Very high PVR with no symptoms, or with large bladder diverticulae, which again shows that there is underlying compromise, significant compromise of bladder or a neurogenic bladder, or patients are not even able to feel that they have such a large residual amount. So those patients we would not treat. I think those will do actually better, if anything, with a surgical procedure. Severe peripheral arterial disease with the CT angio showing poor vascularization. We do not do CT angio as a routine, but if patient has significant arterial disease, then we will do a CT angiogram, which is very rare in our practice. Very rapid regrowth. We do embolization. Patients respond well within 3 months to 6 months. They kind of like have the regrowth of prostate. We would not really prefer to treat those patients again, and I'm probably more conservative than some of my colleagues on that. So when it comes to the common procedures, the gold standard procedures, the TURP remains the gold standard for smaller prostate size, which is less than 80 grams. So is PVP or green light. And then for larger glands, it's mainly really HOLEP, TULEP, and obviously depending on the comfort level, many of the urologists and many of you do, kind of TURP and other procedures up to 100, 120 grams. So simple prostatectomy, obviously I'm going just by AUA guidelines, but these are the ones on the AUA guidelines for large prostate. Though AUA does not define the size, obviously, as we know, but EAU does. So, 50 to 80 and more than 80. So let me now dive into prostate artery embolization and my journey with this procedure over really past almost like a decade. And I say decade because 2011 is when I went to Society of Interventional Radiology meeting, and I saw the first presentation of 15 patients out of Lisbon, Portugal. And it just kind of stuck to me that this is something which does make sense, which can really make a big difference in a lot of people's lives. And this is what I want to spend my career on. And I think 10 years later, I think I've spent easily 10,000 hours on this. So it's really been a remarkable journey for me. And I'll just like really go over very basics. How does this procedure make sense? How is it done? What are the clinical aspects? What to expect after the procedure? And what do we know currently about this? So rationale, BPH per se is a hypervascular condition, though it's not a hypervascular tumor. So embolization should make sense because it will cause ischemia and it will have a threefold effect. It will reduce the size of the prostate, reduce the consistency of the gland, and reduce hormonal action, which will lead to urethral decompression, altered smooth muscle tone, and altered disease progression with ultimately improvement of urinary flow, relief of obstruction, relief of symptoms, and improved quality of life. When it comes to preclinical study, the feasibility and safety of PAE was first studied in dogs in 2007, 2008, actually in 3 different sites. And all those showed 40% prostate reduction with CT with pathological and imaging correlation. First intentional use, 2010, 2 patients in Sao Paulo, Brazil, Dr. Carnevale, who is actually a dear friend. So he actually did the first group in 2009 and presented in 2010. And at the same time, Portugal did their first 15 cases. So how exactly the procedure works? It's a completely outpatient procedure done under conscious sedation. There's an animation which shows the procedure going through groin, where we put a catheter, a base catheter 4 or 5 French, going into hypogastric artery. And then there is a microcatheter, which is advanced further. And this is where most of the challenges come because these vessels are really small. Once it's in the correct position, which is the prostatic artery, then we inject these very tiny, small spheres. And these spheres are essentially made up of polymer coated with gelatin. You can see these white spheres. They are made up of a polymer and they're 300 to 500 microns in size, which is the grain of salt or diameter of our hair. Once the blood supply is blocked, the prostate shrinks in size, and that leads to relief of obstruction. So as I mentioned, completely outpatient procedure performed with conscious sedation, Versed and fentanyl. We do not use Foley catheter. in any of our patients unless they have an indication, or they have retention, or they are doing intermittent catheterization. The procedure can be performed via radial access or wrist and groin access, which is standard. But we actually pioneered the radial access for this procedure, and I'm happy to say I've done over like 700 of these through the wrist or radial access. So what about just a little bit more about the prostate artery anatomy, the origin. Where does the prostatic artery come from? So this is an angiographic image, ipsilateral oblique of hypogastric with 3 vessels, the obturator artery, the internal pudendal artery, and the inferior gluteal artery. So the common origins for prostatic artery, one of the most common ones is what we call as an inferior vesicle, because it comes with the branches going to the bladder. As we know, bladder can have up to 3 branches on each side. So this is the inferior vesical artery origin. Or it can come from the gluteal pudendal trunk, which means that it's just coming directly really from the pudendal, but the bifurcation of gluteal pudendal is a little bit low. Or it can come from internal pudendal artery and obturator artery. So really inferior vesicle, obturator, and internal pudendal are the 3 common origins. And there are some aberrant origins where it comes from external iliac, in up to 5% of cases where obturator comes from external iliac. So we really have to be very careful, know the anatomy really well, and make sure we don't end up embolizing the wrong branches. So once we get into the prostatic artery, again, it's important for us to know that there are urethral branches and capsular branches. The urethral branches running parallel to the urethra supply the transition zone, or what we call as the BPH zone. And there are capsular branches which run along the posterolateral aspect of the gland and supply the peripheral zone. And some of these vessels may pass on to rectum and anal canal. And we are very careful when we embolize this. We do not use small size particles, but if we can, we do embolize capsular branches as well, because otherwise those branches take over the supply to the transition zone. So that's an angiographic image, transition zone, angiographic image, peripheral zone. We have some advanced tools like, cone beam CT, 3D, where we are able to perform intra-procedural CT scan with some 3D reconstruction to see exactly where the prostatic artery is coming from and how many vessels are supplying the prostate. So we sometimes use these advanced tools to, if we have any doubt, to make sure that, we are not in any wrong vessel. When it comes to anastomosis, we are always worried about anastomosis or communications or collaterals to bladder, penile, or rectum. And these are the 3 areas where we do not want these spheres or particles to go, especially penile, because bladder and rectum will just cause a little bit of hematuria or hematochezia, but will not have any significant long-standing effect. But when it's a non-target to penis, it can cause penile ulcer or balanitis, and it takes like good 4 to 6 weeks to resolve. We have had, I think, 3 instances of these out of like over 900 patients we have treated, and all those 3 were smokers. And when they are heavy smokers, we just don't see those communications. So we are extremely careful with patients who have a history of smoking. So again, this is an intra-procedural CT images, which actually helps us to avoid any of these non-target embolization. Once we know everything is safe, then we inject the particles directly into the prostate till we see no more flow, till we see like complete stasis in the prostatic artery. And we use some other advanced techniques like advancing the catheter even deeper into the prostate gland to get more particles in. I just did a live case a few months back, and it was very interesting to see, because there's no real standardization of the procedure, and we do get much better outcome than many of other sites in the country. And I think it really boils down to technique. So, and in this entire journey, whenever there has been any question, be it the safety of the procedure, be it the radial access, all those things, not only we have led all those initiatives, but we have always made sure that we put this out in publication to put most of these concerns at rest. So we didn't even know that if we can use coil embolization safely to block off the blood flow or these small collaterals to like rectum or bladder, or sometimes those small communications to penis. But once we did this study from 2014 to 2016, of 122 patients, we did conclude that it's safe to really coil embolize these branches without having any clinical consequence, including any erectile dysfunction. We did not see any erectile dysfunction either. So once the procedure is done, outpatient procedure takes one to 2 hours, radial access, patient take 2 hours to recover in the recovery area, and they go home. What happens after the procedure? So 3 to 7 days of burning, urgency, bladder spasms, mild to moderate pain, usually controlled by ibuprofen, or sometimes we use Tylenol codeine, mild blood in stool or urine. So and constipation. So one of this symptom can get really worse, and we give meds for like 7 days. All these patients have my cell phone, so they all communicate with me directly, and that's what really kind of drives that. Most of these patients are able to kind of go through this process of the recovery. We do encourage normal fluid intake. I had one patient who just stopped drinking fluid, so he doesn't have to go, and then he ended up with hyponatremia. Activity restriction is really only 2 to 3 days. After the procedure, after this recovery phase is gone, the benefit begins at around 2 weeks post-procedure. Significant improvement seen at 4 weeks, peak benefit at 3 months, and then remains persistent. So this is one of my patients and who's sharing his experience.
It's been just 2 weeks since my procedure. To tell you, I'm a different person now. First, I got on a plane. I'm driving just 10 days afterwards. I didn't have to report my seat on a 3+ hour flight. It was great. Basically, I really prepared me well. The first 5 days, yeah, you had the cramping, that started to go away. The burden was probably the last thing that stayed. 7 days, I was already, after 10 days, it was even more rapid. And you know what, like I said, I'm a new person. My definition of urinating was stop, dribble, stop, start, all kinds of random, all kinds of routes in the middle of the night. Now, it just stop. And I'm done for the night. It's great.
So yeah, I just saw him for, I would say, 4-year follow-up, and he's still doing fantastic. He had around 120 gram prostate, and he got around 40% volume reduction. So what do we expect after the procedure in terms of outcomes? What's the success rate? What's the reduction in the IPSS score? So in our experience, the reduction in IPSS score is around 70%, but some centers have reported around 50%, 80 to 90% success rate. And in terms of the patients who have indwelling catheter or acute urinary retention, is more than 90% success in removing indwelling Foley and staying catheter free. And we mark at 3 months, 90% success in resolution of hematuria, 30 to 40% reduction in prostate volume at 3 months, but very important, no worsening of erectile or ejaculatory function. So on the left, there is an image pre-embolization of MRI and then post-embolization. And this actually, we did a pre-prostatectomy study to study the effect on prostate cancer, which I'll share towards the end of the talk. But essentially what you see is this black hole or an owl eye appearance, or you just see like an overall volume reduction. But what we saw on the explant on the histopath is really these areas of hemorrhagic necrosis, which will resolve over a period of time, and the prostate will just shrink. This was at 8 weeks post-embolization, the pathology specimen. How about other parameters in terms of PSA, uroflow? So PSA, we see around 70% reduction in PSA in our entire practice. Uroflow is around 50% improvement, and PVR is improvement by 50 to 70%. So uroflow, we do not see like 125% improvement like we see in a TURP or HOLEP or any of the laser procedures. Again, this is not like a channel. We are not creating a wide open channel. So how about complications? Most of the complications are self-limiting. And according to Clavien-Dindo or according to our classification, we rarely see any severe complications or class C, including severe UTI, bladder ischemia, or anything requiring further intervention. So it's an extremely safe procedure. So none of the complications in terms of like, need for urinary catheter or hospitalization or retrograde ejaculation or incontinence or urinary stricture. So none of those things really exist with prostate embolization. I did mention briefly about radial access. So we started converting, or we converted to radial access in 2016. And now we are probably the largest series of radial access prostate artery embolization in the world at this point. And again, we published and we tried to set the tone that, okay, radial access is extremely safe and can be used as a frontline access for embolization or for prostate embolization. I'll share a couple of cases here. Case number 1, 62-year-old male with history of green light laser 4 years ago, IPSS 28, quality of life 6, uroflow 3 ml per second, and post-void residual of 170 cc. This prostate is huge, 380 cc gland with a huge median lobe. And I did mention that I don't treat usually more than 3 centimeter median lobe, but this was really an exception. And that really applies to smaller glands. When we deal with large glands, we do go increase median lobe as well. So prostate volume 380 cc, embolization was larger the gland, usually relatively easy embolization. We see a lot of hypervascular blush confirmed on cone beam CT. 3 months follow-up MRI. So 3 months, the prostate shrunk by 50%, 170 cc now. And I think the most amazing thing on this image is the median lobe is almost gone. It's just like a fleck of tissue now, which is kind of floating around, which might have to be removed. But I've seen him in 2 years follow-up, and he's still absolutely asymptomatic. IPSS of 6, quality of life of 0 at 3 months, persistent to 2 years, and post-void of 50 cc. This is really a nightmare. It used to be nightmare, like, even for us. Many times we used to deal with, placing urgent nephrostomies and whatnot. But 71-year-old, Jehovah's Witness, recurrent hematuria, already had a TURB before, indwelling catheter. We performed embolization. Again, radial access, embolization performed safely, and 12 months follow-up, no bleeding, no Foley catheter. So these are like 2 extreme examples of like hematuria as well as significantly enlarged, like giant prostate. So again, even in these 2 areas, in terms of larger glands, we actually published one of the largest series back in 2018. At that time, it was the largest, 93 patients with the prostate volume of more than 80 ml, and another series of efficacy of PA in catheter-dependent patients who deal with urinary retention with large prostate size and high comorbidity scores. So the 80 ml size was 12-month follow-up, and we saw really 90% success and more than 70% improvement in the IPSS score at 12 months. And as far as the patients with retention was concerned, 26 out of 30 patients were able to be catheter-free at 3 months and then going on to 12 months. So what about the current evidence? What do we know about prostate artery embolization just in general, looking at the entire literature? And I'm going to keep it very, very simple in interest of time. I'm going to actually share a couple of meta-analysis. So this is from 2018, which includes 13 studies with over 1,254 patients, which showed IPSS score improvement between 60 to 70% at 12 months. So actually 60 to 70% over a period of time, but at 12 months, it was more like 70%. Same thing with quality of life, as we know, it really runs in parallel. Prostate volume reduction at 30%, PSA was at 40% at 12 months. There's another meta-analysis published relatively recently of prostate artery embolization versus TURP. And what this showed is TURP was associated with significantly more improvement in the Qmax, or maximum flow rate, which I did touch upon, and I think there is no way anything else can compete with TURP, prostate volume, and PSA. So there's so much loss of tissue that you're going to get much more reduction in the prostate volume, much more reduction in PSA, and much more improvement in the Qmax. When it comes to IPSS score, no significant difference between PAE and TURP was observed for IPSS, quality of life, IIF-5 or SHIM score. and post-void reciprocal. PAE was associated with fewer adverse events and shorter hospitalization time. As I mentioned, I rarely keep patients overnight. So these are like really two meta-analyses which summarize, but I think one of the key things which I learned very early on, that by doing a randomized controlled trial of PAE versus TURP, we are just playing in the wrong field. PAE is really not meant for smaller glands, which is where, you know, TURP is the gold standard. So we are actually very close to initiating a PAE versus a HOLEP comparative study very soon at the institution. Just a quick touch on sham versus PAE. I think there was initially a lot of concern from AUA if PAE is even as good as sham, but you know, there was a randomized controlled trial which showed hands down that PAE is absolutely superior to sham. This was done in Portugal. So what about our experience? You know, this is what I presented recently at Society of Interventional Radiology just 4 months back, and it was awarded as the best abstract in the plenary session of 636 patients with 6 years follow-up, the largest series till date in the United States. And again, I would like to highlight average prostate size in our practice, 116 grams, range 20 to 557. 636 patients treated over a period of 6 years. IPSS score reduction, baseline 23.5, at 1 month down to 9, 3 months down to 6, and then continue up to 72 months. Continuous improvement, sustained improvement, same with quality of life, 70%. The prostate size reduction around 40%. And when it comes to SHIM score, we actually saw improvement in the SHIM score by 10%. But we do not attribute this to PAE. We attribute this to really being able to stop the medications. When we look at a subgroup analysis of effect of PAE in more than 80 gram prostate size, at 3 months, 6 months, 12 months, we saw up to 75 to 80% improvement in the IPSS score. And on the right side, I've compared it to many other sites who have published their experience with more than 80 grams. And some of them are in 75 to 80% range, and some of them are like 60 to 65% range. But we consistently do get around 70% improvement. So this is one thing which has not been addressed till now, which is the retreatment rates after PAE. Most of the sites have not reported this. I at least cannot find anywhere in the literature. So we found an 8% retreatment rate, and what we found was that most of the failures actually occurred within the first year. Patients who really did well at end of first year, they were still doing well at 3 years and 4 years. So 52 patients in our series have had retreatments till now, which is around 8%. In terms of medication, when it comes to reduce medication burden, around 80% of patients at 5 years had reduced medication burden, and around 60% were completely medication free after PAE. So what about PAE and erectile function? So this is again one of our manuscripts where we published that, or we collected the data from all the different publications and did like a meta-analysis, and we found that PAE has really no adverse effect on the erectile function. And we presented our experience in Society of Men's Health, Sexual Society of North America, SMSNA, it's just difficult to remember the name, Sexual Medicine Society of North America. And this was actually awarded as one of the best abstracts even there. So erectile function following prostate artery embolization, single center experience of 172 patients. 153 patients were treated for benign prostatic obstruction and 19 for urinary retention. And we found again the same finding as I discussed before, that baseline SHIM score was 17. At 3 months, the average was 18, 6 months was 19, and 12 months was 20. So we found actually sustained improvement in the erectile function post PAE. We have not done any analysis on ejaculatory function, but just by experience, I can say that there is no adverse effect on ejaculatory function. Some patients do report some reduced ejaculate for 3 months or 6 months, but it usually comes back. So what we know about PAE is a niche application in larger prostates, acute urinary retention, and hematuria. The symptom improvement is comparable to surgical procedures like TURP and laser at midterm, 12 to 24 months. Effective subjective parameters at 12 months and up to 5 years, at least in our series. No adverse effect on erectile or ejaculatory function. And I would say safety of the procedure has been established, especially in experienced hands. So again, whenever you see these large 300 plus, 200 plus gram glands, those are really best served by embolization. So niche applications also really patients with urinary retention, prior surgical history, refractory hematuria, large glands, poor surgical candidates, and men wishing to avoid any sexual side effects. So what does current Society of Interventional Radiology position statement is exactly what I just mentioned, is that it's an acceptable minimally invasive alternative treatment option for appropriately selected men with BPH and moderate to severe LUTS, especially in patients with larger than 80 gram prostate size, patients with acute or chronic urinary retention, and patients who wish to preserve erectile and ejaculatory function. When it comes to European Association of Urology, we do see that there is not an obvious indication in terms of what size, but they have included that patients with larger prostate may have most to gain from PAE, and this was actually based on actually our experience. They actually quoted our experience for this. The selection of LUTS patient who will benefit from PAE needs to be better defined and should always be done in a multidisciplinary collaboration with urologists. So when it comes to American Urological Association, PAE is still not in the guidelines, and we do work closely through SIR with AUA, and I'm still very optimistic that the role of PAE should fit into large prostate, along with simple prostatectomy, HoLEP and TULEP, especially more medically complicated patients, patients with higher risk of bleeding, and patients desiring to preserve sexual function. So if we look at the whole paradigm of surgical therapy for BPH world, the procedures which are extremely effective, which are great, which are gold standards, TURP, HoLEP, they all give around 70% improvement in the IPSS score. But obviously they have risk of ejaculatory dysfunction of 65% and 10% ED. And that's why the tolerability of these procedures remain low and a little bit less popular amongst patients, and patients do like the procedures which do not have those sexual side effects. And that's where the outpatient procedures, the office-based procedures like thermal ablation, prostatic urolift, resume, those become popular, but they really give around 50% improvement in the IPSS score or symptom score. And then medications obviously have none of those major side effects. It does have some ejaculatory and ED side effects. But when it comes to PAE, it is very promising because, again, in a very specific subgroup, because it is relatively very effective with no EJD or ED, no incontinence, and no inpatient requirement, no Foley. So what has our journey been is, we have been, at least for me, for my career, I've been really, really honored and humbled to be, leading this innovative procedure. We have performed most number of PAEs in the United States, but right from beginning, our focus was really providing exceptional clinical care, work on patient access, make sure all the patients have access to me or us or our team, make sure we are leading in terms of research, make sure we are leading in terms of education. And I've personally trained over 300 IRs how to do this. But I do want to mention that this procedure has a steep learning curve, anywhere between 50 to 100 procedures. And that's where many and most IRs will start doing it and kind of stop doing it. We have been instrumental in setting the standards for the procedure. Our procedure times have gone down by 50% now. It used to be 2 to 2.5 hours. Now most of them are under 90 minutes, average is 60 minutes. We took the lead in radial access. We set the standards in terms of how to do post-procedure management. And now we have worked significantly on reducing radiation associated with the procedure. And I think one of the key aspects for all this has been the collaboration with our Department of Urology and all of you, and all the urologists in South Florida and beyond. I'm honored to say that I actually have some urologists, not only out of South Florida, but out of state, who have logged on for this webinar today. So thank you, all of you, very much. And then obviously working with all the societies, including AUA, SBPD, which is now obviously a new subsidiary of AUA, SIU, where I just gave a talk like literally last month, and I had 1,500 urologists from all over the world. So it's really very humbling to be in this position. And we just a few months back, we published this an entire issue in Techniques in Vascular Intervention Radiology on PAE, which essentially is like a holy grail now, like almost like a book on PAE. And we have been featured in different areas, including like different media, Miami Herald, local news, and all those things. So again, it's really been a great experience for me. And again, I want to thank our Department of Urology and all of you for your continued support